of Health. Can we bow our heads in prayer? Dear Lord and Heavenly Father, as we're gathered here this morning to do the work of Jamaica, I ask for your guidance and your blessings on the proceedings which are to take place. Lord, we thank you for all the blessings that you have bestowed on us thus far, and we commit to continuing to work at your grace. In your name we pray. Amen.
Thank you very much. Thank you very much. Okay, so item 3 on the agenda, apologies for absence. I have a list here. I'll just read them into the records. MP Holness, MP Malahu Fort, MP Crystal Lee, MP Dr. Brown Burke, MP Hilton, and Senator Longmore, who is now here. So she wouldn't qualify to be late because we just started. All right, are there any other names? No? I think that's fine. All right, in terms of my quick welcome and opening remarks, firstly, of course, I want to welcome the members who are here. I know it's a difficult time of the year for all of us. Whether you are a member of parliament, like myself and Member Guy and Member Hamilton, I know there's a lot happening on the ground now, a lot of pressures and expectations. And of course, the health team who are busy preparing to deal with all the surges of one form or another during this period of time. So I know it's challenging. So I want to just make a special thanks to you for being here. We're going to try and go through as quickly as possible because the truth is we serve an important purpose in providing an update, interrogating the programs around COVID, which remains a threat. Having said that, as you will see in the report, we have been able to break the back of this third wave, which has really been a challenge for the population, for all of us. But we are going into the season when there are vulnerabilities, and I think it's worthwhile to have this session leading into the holiday season to explore and to reaffirm and reinforce the approaches to the programs that we have and for the Jamaican people to understand. So I think this is in keeping with our duty to the population at large and to the commitment that we have made. I want to just use the opportunity to thank you over the last year. This will be the final meeting before the end of the year, unless there's an extraordinary circumstance. And I want to thank the members of the committee for meeting periodically and for the worthwhile contributions that they have made. And to the health team, for the record, just to thank them for always being available to contribute to this cause. All right, so if there's no other comment around the welcome and opening remarks from anyone, I want to move now to item 5, which is the reading and confirmation of the minutes. This is in specific relations to the July 20 meeting, 2021. And I'm going to take it page by page, as we usually do. Pages 1. Page 2. Page 3. Page 4. Page 5. Pages 6. 7. 8. 9. And the final page, page 9. Okay, so if there are any, can I ask if there are no corrections for the confirmation of moved by Member Hamilton, seconded by Senator Campbell Rodriguez. All right, matters arising from the minutes. If it's a matter that could be addressed in the presentation, I ask you kindly to await the presentation. Otherwise, are there any matters arising that you may want to raise? No? All right, excellent. We're moving very nicely. So at this time, I'm going to ask the team from Health to give the updated presentation on the current state of COVID in the country and some of the measures that are being implemented, and included in that some elaboration on the fourth wave preparation. Are you doing that? We kind of did that last night at COVID Conversations, but maybe, well, I'm sure it will come up. I know Member Guy, he's going to ask about that. So just present and then we take it from there. All right, so PS, you want to introduce the team or Dr. Webster-Carr? You're the senior one there, so I'll hand over to the Permanent Secretary to do the introductions.
All right, thank you, Chairman. Members, good morning. So I am going to defer to Dr. Webster-Carr or Dr. Simone Spence to introduce the team. But just to say, Chairman, we are happy to be here to update on our progress to date and also our plans for 2022. Dr. Spence, who's acting as CMO.
Morning, everyone. Dr. Simone Spence, Director, Health Promotion and Protection Branch, Ministry of Health and Wellness. The mic is on. Not hearing? Okay. Sorry. Dr. Simone Spence, Director, Health Promotion and Protection Branch, providing coverage for the Chief Medical Officer's desk. With me is Dr. Webster-Carr, who is our National Epidemiologist. Behind me is Dr. Shaw Kelly. She is a Program Development Officer in the Family Health Unit. And Dr. Nadine Williams, Director of Health Services Planning and Integration. She has stepped out briefly, but she's also a part of the team here today. Thank you.
I'm sorry, Mr. Chairman, if I could ask if you could go closer to the microphone. Yes, thank you.
Okay. To repeat? Oh, okay. For the next, okay, no problem.
Okay, over to you then, Doctor.
Okay, thank you. Good morning, members, and morning to my colleagues. So today I'm going to present on information, a bit of the numbers, the epidemiology, and a little bit on the vaccination. So as of yesterday, when we got 59 new cases, we are up to 91,927 confirmed cases.
Sorry, Mr. Chairman, to interrupt. I just want to ask her a question so that I get the context. All the data in here is as of yesterday?
Yes.
Okay.
If it's not, then I will indicate.
Okay, thanks.
So, because some are previous weeks. Yeah. So we have currently 22,433 deaths with a case fatality rate of 2.6%. Yesterday, we had a daily positivity rate of 3.3 and a 7-day average of 4.9%. This is the first time in months that we have gone below 5% in our 7-day average. With respect to the age of the confirmed cases, the highest burden is in the 20 to 29. This has not changed, and followed by the 30 to 39 age group. But when we look at the deaths, if we start at the under 10, 1 in 1,000 babies or children would have died. But when we reach to the older, more than 1 in 5 persons have died. For sex, more females have been confirmed to have COVID than men. And, but when we look at the deaths, more males have died than female, with a greater case fatality rate, significantly so. With respect to the parish distribution, I draw your attention to the lower half of the, or lower portion of the charts with the last 2 weeks, which gives you an indication of what's happening currently. So when we look at number of cases, KSA, St. Anne, St. James, and St. Catherine have the highest number of cases. But when we look at number of cases by population, then Hanover, St. Anne, and St. James have the highest number of cases per population. I hope your printed copy looks better than this, but as of the 14th, 23% of communities across the country have cases and distributed as seen. So what has happened over time with the, this is as of the 14th, and we added 1 death, so it's pretty much similar to what we would have here. The number of deaths, just bare numbers, it will be greatest in St. Andrew, St. Catherine. But when we look at the deaths per population, then St. Elizabeth, Trelawney, and Hanover has the highest number of deaths per population. However, we have a number of cases under investigation, so we chose to add this to the parish numbers and give us a rate. So if we were to classify all the deaths under investigation as COVID-19 cases, this is what we would look like. And then when we do this, then the picture changes a little bit. And Hanover would have the highest number of deaths per population, followed by St. James. When we look at the number of confirmed cases in blue, we have come out of the 3rd wave, and we are now what would be considered interwave period. And the numbers have been going down steadily. There might be a little leveling off there. With respect to the admissions, which is the pink one, the general trend is down, a downward trend. For the parishes, the curve looked pretty much like the national curve, except for Portland, where the number of cases in the 2nd wave was less than that in the number of cases in the 3rd wave was less than that in the 2nd wave, which is unusual, and it may indicate decreased testing in Portland. When we look at the weekly numbers, we see that the week ending 4th of September was the highest number of cases, and so far the greatest number of deaths. There has been a general decrease in cases and deaths and positivity rate since that time. With respect to admissions, this also has been decreasing, number of persons in bed, but there's some leveling off happening there. With respect to among the hospitalized, those who are moderately, severely, and critically ill, we see the peak, the large peak in August and September, and we have leveled off, and in keeping with the numbers that we have spoken of before. So this, as of yesterday, only Port Maria Hospital was in red alert for isolation, and in amber alert, Savlamar Hospital was in amber alert, which is 77% for isolation. But when we look at the general wards with non-COVID cases, then we are in red alert, western region and southern region, and we will note the hospitals that are in red alert by region. With respect to occupancy level and the pressure on the hospitals, in general, it has been decreasing. We are just above medium level, so we are at high, but almost into medium level of pressure on the health system. With respect to the reproductive rate, for the number of admissions, we are at about 1, and for the cases, confirmed cases, we are at about 0.9. So decreasing a little bit on cases, but we are static where admissions are concerned. This is our positivity, daily positivity rate. The general trend is downward. We are out of the third wave, and for the first time yesterday, we went to a 7-day average of 4.9%, below 5%. So when we look at the weekly numbers, our highest positivity rate was in week 34, and since then, a general decrease downward. This one, I hope it's kind of hard to read. So those are the general numbers. We just want to explain a little bit about the vaccination guidelines that we have. So for persons over 12 years and older, we are eligible for vaccination. And we will give what is called a primary series of vaccine. And this is the number of doses recommended to confer adequate protection against infection, severe disease, or death. However, we know the immunocompromised person may not be able to mount a very good response and get adequate protection. So these immunocompromised persons would, we would extend their primary series to probably an additional dose or doses to enhance their protection. With respect to over time, many vaccines would, your protection would decrease over time. And in that instance, a booster would be recommended. And this is the dose that would restore protection that may have decreased in that time frame. So there are 3 principles that we were speaking about: the primary vaccine series, the extended primary series, and the booster. So with respect to the vaccination guidelines, if your primary series was AstraZeneca, then your extended series would also be AstraZeneca. There is not yet a determined booster for AstraZeneca, but we are recommended Pfizer at a 6-month interval from your second dose. If you obtain a Pfizer vaccine, then your extended series would be Pfizer. And if for a booster, you would be eligible for Pfizer at a 6-month interval. If you have received Johnson & Johnson, the extended series would be a second dose. And if for a booster, you can either have Johnson & Johnson 2 to 6 months after, or a Pfizer 6 months after. That is the recommendation. So as of December 13, the persons eligible for these boosters were adults 60 years and older, healthcare workers, and persons who have received 1 dose of Johnson & Johnson. As of yesterday, the 15th, all adults 18 years and older are now eligible for the booster. So this is data from yesterday morning with respect to the vaccination coverage. Of 1.17 million persons, doses have been given, representing over 700 persons at a 25.6% coverage. So just to give you an example from last week, we have done a number of vaccination at different sites that are listed there. The sites are listed, number of sites, how many sites we have added. We added last week, which last week we really didn't add any new sites. But when we look at by site type, the fixed sites that are health center would give them the greater proportion of vaccines, followed by the other fixed sites. There are mobile sites. Of course, that will be less because, you know, you have to drive from person to person to give the vaccine. But the community operation had 5,509 doses that were given, as well as we have shut-ins, which we did 20 last week. This should look better on your printed copy because it's washed out. When we look at the deaths between March this year and December this year, we had 1,900 deaths, and 98.5% were unvaccinated. 0.7% were partially vaccinated, and 0.8% fully vaccinated. And so the case is clear for vaccination. When we review the coverage by parish, parishes with the highest coverage were KSA, St. James, St. Elizabeth, St. Anne, Trelawney. And those with the lowest were St. Thomas, Portland, St. Catherine, Clarendon. And this is the coverage so far. So what is clear to us that older age group is associated with increased risk of death. And we have prioritized the older age group in vaccination, and we started with them first. We need to continue that to ensure that our older persons who are more at risk for increased severe disease and death are targeted. So when we look at the vaccination coverage by age, persons in their 70s had the highest coverage, followed by persons in their 60s. But we would want to have this greater, these persons, it should be 90% or greater coverage in these age groups to really have the best effect and protection from severe disease and death. when we look at sex distribution of the deaths, more males, but also what we have noted is that in time, the number of male deaths have decreased compared to female deaths, which was not seen before. And one of the things we looked at was that when we look at the vaccination coverage by age group and sex, overall, females have a better coverage than males. But when we look at this person 70 years and older, the coverage is better. And this may be what is fueling the comparative less deaths in males than females that occurred in the peak week of the peak month. Yes.
Oh, I'm sorry, could you repeat that vaccination and male-female coverage,
Right.
please?
So what we, in general, males have a higher case fatality rate than female. Males have a higher death rate than females. But what we noted in August of this year, in the peak of the third wave, was that there were more females dying than males. And it struck us, what was the reason for this? Was it the variant that was predominating, which was Delta at the time, or was it vaccination? So we sought to look at the vaccination. And when we looked at the vaccination, then we noted for the older males, their coverage was better than the coverage for the older females. Yeah. And we also looked at the number of lives saved, and when we looked at the lives saved for the over 70, there was more male lives saved than female lives saved when we looked at that. So this is the picture. It's looking good at this time, but we have to be careful in that for the most of the indicators, we are above where we were at in between the second and the third wave. So we can still increase rapidly if we are going into the fourth wave. So the geographical spread is at low at 22.9%. Bed occupancy is still at high pressure, but going into medium. The positivity showing that low transmission level at 4.9%. And the cases are decreasing. However, the vaccination level at this time is too low to have an effect on transmission, although it's obvious that it's having an effect on severe disease and death. So that is the presentation for today. Thank you.
Thank you very much, Dr. Webster-Carr. So there you have it, members, the current status of our COVID response. We, as I said earlier, can conclude that based on our 7-day average of positivity at hovering around 5%, our reproductive rate below 1, our hospitalization, which has come down fairly significantly, less than half of COVID beds being occupied, half of that, 25% or so, confirmed COVID cases. The others are suspected cases. And the deaths, which clearly every death is regrettable, is also coming down. So I think it's fair to conclude, despite all the challenges that we have had, that as a team, and indeed as a country, we have been able to stave off or to respond effectively to the third wave. And we want to just recognize those on the front line and those who have had to marshal the troops and provide the coordination. It has come at some cost, clearly, in other areas, and we are going into the Christmas season. And I think that the real conversation now is how we move forward, because I don't think there could be any debate around how we have traveled up to this point, and in certainly the third wave response. It's really about going into the season, going into the new year. What are the expectations, the preparations, and how do we confront some of the decisions that are going to have to be taken, living with COVID being a key theme, and what is the level of preparedness and work that has to be done. So still a work in progress, but I think the committee's time may be more valuably spent looking at that, even though I'm not trying to influence Member Guy.
And I'm glad you did, Chairman.
What exactly we want to place on the table for discussion. All right, the floor is open. Member Guy, you want to begin? Okay, and then we go down.
Thank you very much, Chairman. I want to thank Dr. Webster-Carr for the presentation. And not aping you, Minister, but I want to also thank them and congratulate them for the work that they have done over the past 20 months. Just a few considerations. And Minister, you and I had this discussion, well, the Prime Minister, and then downstairs you and I had it. But I just want to find out from, and Dr. Spence, you are acting as CMO, the booster recommendation, the WHO has still not offered an opinion on booster recommendation, except for those persons who are immunocompromised, and suggestion about healthcare workers as well. Boosters for the general population. I asked the Prime Minister the question in the Parliament, what agency or what recommending agency are we utilizing where booster recommendation is concerned? I know FDA has, CDC has as well, but our reliance on FDA, our reliance on WHO has been what has guided us over the years. Could you say which one we have utilized in this new dispensation? Secondly, Minister.
Yes.
Sorry.
You're going to ask a follow-up, or you should?
No, there are other questions, but I yield to you.
Right. Now I was saying I want to comment on that, but I would also want the clinicians to give the clinical response. But I can give a general policy response, because I think the policy response is important. The first thing I'd say, member, is that the WHO, while it provides critical, very important technical guidance, we are members of that very important body, and we depend on the expert committees to advance, in particular, clinical advice around the use of vaccines and the sort of clinical response to the pandemic, the virus. The WHO does not, however, at the same time, there's no automaticity around WHO recommendations and a particular country's decision to comply in full or in part with those recommendations. It's quite clear that countries do reserve the right, based on their particular context and circumstances, to deviate or to vary without devaluing the contribution of the WHO. First point. So Jamaica is well within its right to offer some deviation. The second point, however, which is very linked to the first, is that my understanding, having been at the forefront of kind of studying and trying to appreciate these issues, is that the WHO's contention around booster shots has not been the effectiveness or lack thereof of a booster, because the science has been very clear that for different brands, the efficacy or the effectiveness does deteriorate over time. The J&J, for example, you're looking at 2 months after the first dose, is now being recommended for a second. The Pfizer, science is suggesting after 6 months, you're losing a lot of the effectiveness, so the booster is recommended. I think that science is very clear. The WHO's hesitance in recommending boosters is not around the clinical or the science. It's more around the equitable distribution of vaccines. The WHO has always contended that to promote or recommend boosters could mean that parts of the world where vaccines first dose or second dose is not available will become even more difficult for those countries, parts of Africa and other parts of the world. And so what I have heard them say time and time again is that the world needs to come to terms with providing vaccine equity or access globally, which is the best approach for the controlling of the virus, for controlling variant strains from emerging, before we start to focus on providing additional doses in the form of boosters. So it's less a clinical response and more a vaccine equitable access response. In our case, we had, but no longer have, an issue with vaccines. And as I said last night at another place, we have some 1.1 million doses representing 4 brands of vaccines in stock, more than enough to inoculate another 500,000 or so Jamaicans. We have significant hesitancy, and indeed, we are dumping vaccines. If the science supports boosters within a particular protocol, it is very logical, I believe, indeed very sensible, for those who have taken the time to take the first and second dose, as the case may be, and now require a third in the form of a booster, for them to be given that opportunity, given that we run the risk of dumping vaccines. And so the decision is scientific, but it also addresses the issues of access, given that we have inventories in stock and we're dealing now with Jamaica, not the world. And therefore, I think we're well within our right to deviate from the WHO's posture, even though I don't think it's much of a deviation because they do agree with the science around the vaccines and the length of time. I don't want to be a clinician member,
Chairman,
so I gave a policy position.
Before you go,
yes,
I just want to correct something. It is incorrect to say that the WHO has not ruled simply because of equity. There are 2 concerns that WHO has. One is equity of vaccination, but it is also, which is why the strategic group of experts, advisory group of experts, are deliberating on whether booster shots are to be administered. So it's not just a policy decision. I don't want anyone to get the impression that I'm against booster. I am for it. I just want to know, having regard, Minister, and a policy decision I understand is done by the policy makers. But I mean, you came to the Parliament on the 30th of November and said that as it relates to booster shots, we are guided by WHO recommendations. And that was the problem I had. You know, so if we have changed it, then say we have changed it. You know, but my particular position, and I'm totally in agreement with you that is within the country's right to deviate from WHO, as we could have for other things in the past that we have knocked heads over. You know, but that's just the point I wanted to make. You know, and you have explained it that it is a policy decision and not necessarily a clinical one, because the clinical position was always there that it could have been done. CDC did, FDA did, right? And we as a country, we have our own experts here who could interrogate the data and say, okay, it is. I am for boosters. Lest anyone gets that missing.
Get the point. And I'm going to ask members to comment if they are following on to this. But I just want to say that we have articulated that, and I've repeated it a while ago that the issue of boosters in this instance is a function of availability of inventory. When others were offering it and we did not offer, or we offered it on a limited scale to 60 years and over and frontline workers, it was also because of access to the quantities. But this past week, we got an additional 204,000 doses of Pfizer, which is the most commonly recommended boosters across all the other brands. And so we are now in a position where we can. So there's a practical equity and the science. And I think on all fronts, we have taken the right decision, member. But I'm happy you have said that you are for it. And if there's clarity, this is why we clarify these things. So I think the opportunity is worthwhile.
Mr. Chairman, I just want to say, and I can send the document from the WHO to you, MP Guy. They state here clearly, the decision to recommend a booster dose is complex and requires, beyond clinical data, a consideration of national strategic and programmatic aspects, and importantly, an assessment of the prioritization of global limited vaccine supply. So the WHO, it's not that you're deviating. The WHO has said clearly it is at a national level that the consideration needs to be made outside of just a clinical one. And so...
Asking when was this?
Sorry? I'm going to send it to you now. It's their most recent output that they have done on booster shots, the most recent. So I'll send it to you, member guys. So if you can send me your email address and I'll forward it to you. So I think it's within the government's remit to do so. It's not deviating from WHO at all.
Thank you. Member Hamilton, you wanted to comment on this point?
Yes, Chair. So my issue is really more of a resource concern, because we spoke about, not hearing me? Oh. We spoke about the vaccination coverage and the hesitancy that we have. And you made mention of the study showing the efficacy waning over time. Let's top it off to 6 months. For me, if we continue to have this hesitancy and low coverage, we will be required to have boosters minimum every 6 months for us. So at what point, how do we deal with that? Because we'll forever be having to provide boosters to the population because of these variants that are coming out. And I see they seem to be coming out quite often. Because of our low vaccination, we are exposed. And we'll continue to be exposed until we increase the numbers. So for me, it's just a vicious cycle. It's just an observation that I've made. And it will be the same persons who will keep, having to take these boosters all the time.
All right, so I think we're aligned, Member Guy, myself, Member Campbell Rodriguez, on the point. I don't think we should cite any major difference unless the clinical team thinks otherwise. Can I ask someone on the team to comment on what Member Hamilton spoke to? Because I think there may need to be a clearer, more scientific explanation around the need for further boosters if we have low hesitancy. I'm not sure that that's the scientific explanation. Maybe it needs a little clarity. Dr. Webster-Carr or Dr. Spence, you want to come in there, or anybody else on the team?
Thank you. I'm not sure I understand. So I'll answer, and then you can ask me to clarify after. So I picked up two issues in what you're saying. One is a coverage issue. And I think even before boosters, we have to push to get the coverage greater for persons. So the persons need to come out and get vaccinated for protection. That's the first thing. The second one was related to the necessity for booster periodically, whether it's 6 months or a year. It's not necessarily, it is a global phenomenon, not necessarily a local one. So if as a world, we have low vaccination coverage, then the risk of variants occur and there are changes in genes, that the coverage, the vaccination may have to shift a bit to allow for protection. And similar to how we would have the flu vaccine that is recommended annually, it will be a similar effect.
So that is really what I was getting to, you know, the regularity of it. So clearly we may have to take boosters over time in the future.
Correct.
Member Guy, you weren't finished your questioning. You want to go ahead with the next one?
Thank you, Chairman. Just a couple of comments on the presentation. I lied to the presentation, the daily report of the COVID numbers by the ministry. We noticed that there is a tendency now to give the deaths over a period of time, whereas we were giving them on a daily basis as to when they occur. It gives a false impression to the country as to what actually is happening. And I would encourage the technocrats at the ministry to give the deaths as they occur, I mean, on a daily basis for the previous day, as is the case for everything else. And then you can also have an addendum as to those that have been under investigation and have come forward. I gather, though, Minister, and it is something that the regions need to do, is to send in the results to the ministry on a more timely basis. Because if you look at the reporting, what you see happening is that you have, say, one particular parish occupying the significant number of deaths on a particular reporting day, which suggests that it is just coming into the ministry so that you can add it to your numbers. And secondly, the number of deaths under investigation is rising, and I would, although we have seen in one of the presentations where the deaths under investigation have been added to the numbers of deaths to give a picture. The reality is that those teams in the respective regions need to get together so that they can have a proper determination on these and have the numbers verified so that they can be either still remaining deaths on the investigation or deaths. Now, I have another concern, and if you allow me, Minister, I'm a little parochial. Because when I look at the numbers for St. Thomas, or before I go there, the numbers that are reported in terms of deaths in the parishes, are they the hospitals in the parish or the place where the persons who have died lived?
Place of residence. Place
of residence, fine. And it supports my point even more, because we have more cases of COVID-19, and I'm making a comparison to two parishes, St. Thomas and St. Mary. We had more cases in St. Thomas than in St. Mary. And, but what we're seeing here, based on the presentation, is that our death rate in St. Mary is much higher than in St. Thomas. And it brings me back to a question I'd asked some time ago, very earlier on, Doc, about management in the respective hospitals. Because is it therefore that St. Thomas is, though they have a higher number of cases of COVID, are managing their cases better than my parish in St. Mary? And I'm a little worried about that, you know? And I'm sure the senator from my parish is also worried about that too. What is the situation? Because, I mean, if you look at the death rates by parish, we see that St. Mary, although we have had 98 deaths and 67 in St. Thomas, our rate is 86.3%, and St. Thomas is 71.4%. So, but even without the rates, look at the numbers, all right? But the rates, I think, per 100,000 give you a better feel as to what is happening. So can we get some clarification or some information on that? Because it is a little concerning.
And to support you, member, and you know it's not often I agree with you,
I'm worried
but Fort Maria is the only hospital that you red flagged. And my grandmother and my cousin just died in that hospital on the same day from COVID. So there is a St. Mary problem. it was the only one that was red flagged in your data. So I'm curious as to that response to what member guy is saying.
Good morning, team. I would just like to make 2 responses. And one, with respect to if there's disparity between the understanding of management, between parishes, between hospitals, there ought not to be in terms of understanding, because the clinical management guidelines has been dispersed and discussed with all the teams together. Furthermore, we continue to be a resource for all the teams. So if there is any issue with management of cases, then it is that we have a common, we're a common repository for answering the questions as it relates to management of cases. Therefore, the doctors in St. Mary, the doctors in St. Thomas, etc., do have the same clinical guidelines. The question clearly is the equipment, is the infrastructure, are the capacities similar? Capacities are dissimilar between hospitals and so on, and so I can understand that question. And certainly, I believe that a specific response would require some detailing on a case-by-case basis. So that what Dr. Guy presented as a disparity in terms of the case fatality rate or the outcomes being different, despite the numbers being different between parishes, is certainly something that needs further a deep dive. Nonetheless, it's funny that you should mention Port Maria. I was actually there yesterday, so I was able to see the cases. It's a little bit, how should I put it? It's not exactly what you're seeing, because it's not like we're having a number of cases at Port Maria. The fact is that Port Maria's capacity for COVID cases and isolation is really very limited, because they were not intending to have any cases there. It was just a holding area to move on. So when you see that there's a large percentage, it really doesn't say that there's an overflood of cases at Port Maria at all. In fact, there are more cases at an Otter Bay hospital where I mentioned. So to say there is definitely a problem in St. Mary perhaps is not the absolute truth.
Dr. Williams,
and I'm not saying truth, I'm just saying
the numbers of beds in Port Maria, because it is important. Even though it's 150% we're having, I think it's less than 10.
Right. So the numbers of beds, the numbers of, and the relative proportion of those beds that are occupied is really what we're reflecting on when we say in the red.
So you're saying it's not as bad as it appears by the ratios that are quoted. You want to clarify that, PS?
Yeah, I just wanted to add to the conversation by saying that my understanding of the numbers that you're seeing, even for deaths, there are times when someone, as Dr. Epsakar pointed out, the deaths are recorded by place of residence. So someone who would have died could have been transferred to KPH, or be transferred to UE, or be transported to St. Anne's Bay, or be transported to any hospital, and would have demised at that hospital. And so to do that correlation between the deaths, and the number of deaths in the parish, and the capacity of the hospital or the infrastructure in the hospital might not be the best alignment for the indicator that we are measuring. It is true that the case fatality rate in St. Mary is high. In terms of the interrogation as to why that is, we have to look at what happens. Are persons coming to hospital in time? Are they staying home and doing home remedies before they come to hospital? Is it a case of the distance of health facility from your place of residence? Those are factors we'll have to investigate, both in St. Thomas and St. Mary, but to make the correlation between the capacity of the health facility, because in St. Mary, my recollection, I could be wrong, it's only one type C hospital that is there, yes? Port Maria, it's a type C hospital. And then you have an Otter Bay, which is a quasi-type B. It's a quasi-type B. So in terms of infrastructure for complex cases, for cases that might need referral into a Type B or a Type A facility, those issues would have to be brought into the conversation as well.
Thank you very much. Can I move on now to Senator?
Thank you, Mr. Chairman. So on a number of, good morning. On a number of occasions, we've heard consistently about the projected fourth wave. And I think like all Jamaicans, we would, and I'm sure in various other spaces, this has been ventilated with some sort of clarification for people to fully appreciate what is projected from the ministry's perspective, what is to be the fourth wave, especially in light of we're 2 weeks or a week or so away from the season where more people are likely to interact. So is there any further information other than a projected fourth wave that we could gather from you in order to fully appreciate the importance of even more stringent protection of ourselves so that we can communicate to the public how urgent that is? And I say that in light of the new strain that has so far caused, and it hasn't been mentioned specifically here, Omicron, in that we have seen just today announcement by France where they are seeking to ban UK travelers through their borders, non-essential UK travelers as of Saturday. So for us, and we know many Jamaicans abroad, and the UK in particular, are likely to travel. I wondered whether the ministry had any thoughts on that, or whether we wanted to go further in appreciating your concerns or position with regard to travel and also with regard to Omicron. I suspect, I only have 2 more comments. I know a number of persons who have so far taken the booster shot. And kudos to them, like Member Guy and others here. I am encouraging, and as soon as I'm in a position, I'd like to think I'm not ready yet. But nevertheless, there's probably need for some communication to put people's concerns at bay. And as Member Hamilton mentioned, it's almost as if we're communicating to the same set of people who are already in the mindset of taking a boost or taking the vaccine in the first instance. But from my observation and feedback from those who have taken it, the reaction to it, I wonder whether there's any report that the ministry is tracking as to reaction to booster shots, and whether it is just outliers or this is something that might need to be communicated with some amount of clarity to allay any concerns that people might have. And finally, in one of the slides, there was mention of the capacity with regard to non-COVID or non-isolation capacity and the percentage of, those in red alert or amber. And I noticed the information is there about Falmouth, Sav, Cornwall Regional, Noel Homes, all being in the red alert along with others. Is there any further information to help us to appreciate what these other how do you break down the cases of non-isolation and how they might be categorized? I happened to have been in the bank yesterday and was in a discussion with Dr. Frey from Cornwall Regional, and obviously this is a subject of concern in terms of non-COVID patients. So if you could help me to understand and appreciate the categorization of non-isolation cases, if it's possible. Thank you, Mr. Chairman.
Thank you. Can I ask the member of the clinical team to respond, starting perhaps with the last question?
Thank you, member, for your question. In terms of the numbers, in terms of the hospital data that you're asking about, the COVID isolation, you do know we had built out capacity specifically for those patients. And when we talk about the non-COVID isolation cases, it would be referring to all the other types of patients that we have in hospital at that point in time. And we also recognize that, especially at this time of the year, as we come on to the colder months, we do have more cases of respiratory illness, as well as our chronic disease patients as well tend to be seeking medical care at this time. And so the general capacity of the hospital tends to be under strain, especially at this time of the year. As well as the increase in trauma cases, you know, coming in at this time of the year, especially from motor vehicle accidents and so on. And so, generally speaking, this is usually the pattern that we see towards the latter end of the year, early January, for the non-COVID related. So we just separated both sets so that we can account for the COVID persons.
Okay, so I'm sorry, Mr. Chairman. So at some point, is it possible going forward maybe to have a sort of a breakdown, if that's even realistic, or just to speak to, is it just that, just generally, the hospitals are a little stretched?
Okay, I think on a daily basis it will be something difficult to do. What it comes in as a monthly report from the hospitals. So there's a lag between the time. So to tell us how many surgical patients we have, how many persons with non-communicable disease, and that's broken down a little bit more. So that doesn't really come in on a daily basis. This is a census we do to track COVID and non-COVID and to get a general idea of what's happening in the hospitals. Yeah, thank you.
What about the comment on boosters? Any comments on that?
So we do not have the data disaggregated at this point in time in terms of if SAV is directly related to booster doses, because we would have just started the booster program earlier this week, I think on Monday, when we had it limited, and now, based on the announcement yesterday, it has now been opened up to the general population. But we continue to get our reports on the number of ISAVs since we started the vaccination program. And so, remember, we can indicate, this is just the aggregate report. I don't have the breakdown in terms of the types of cases. We have overall reported so far 738, and 165 would have been designated as serious. So that's what I can provide at this time.
And the issue on ban, thank you, colleague. The issue around banning, restrictions on countries coming in. You would have heard that we have announced the lifting of the restrictions on the, sorry? Yes, and there is never a desire to you know, it's not a desired position to have restrictions on any nationality, and in this case, countries that we're close to, friendly with, and who have been supportive. But it is one of the responses that has been fairly consistent in dealing with the pandemic, the virus, its spread, and their major objective being to slow it down, not to keep it out, because it just wouldn't be practical. In this case, the virus is present in over 70 countries now, Omicron, the variant strain, and there is no practical value and indeed no possibility except for a total lockdown of the country, which would clearly not be practical either. So it would be unfair to restrict particular countries at this point in time. In the early stages, based on the information we had, it was a deliberate decision to achieve a particular end, knowing fully well that over time that particular objective would not be worth trying to achieve.
Minister, just for clarification for the record, I wasn't suggesting or calling for any adjustment to that policy. I was merely indicating that with the expected travel that we usually see at this time of year for persons from the UK to Jamaica, it's even more important for us to reiterate the concerns with regard to all of what we have to deal with because of the transmissibility that we are aware of with Omicron, and we're in a season where there's going to be more interactions. So I just wanted to see how we were appreciating or approaching that because of the obvious impact that it could have, especially with the projected fourth wave and how we're handling the projection for the fourth wave.
Well, I would venture to say, and at the risk of appearing to be an alarmist, that's not my intention, but I would venture to say, given what we know of this season and the interactions that are likely to take place, cross-border interactions, whether diaspora or tourism related, it is highly likely that if the virus isn't here already, it is highly likely that it will be here after the holiday season. And I think we have to be frank about this. I think we have to make it clear to the country, which is why we have continued to emphasize the wearing of the mask, physical distancing, the observation of the protocols around gatherings, and indeed, where one is in doubt because they have symptoms or feel exposed, they should get tested. It is part of the preparation for the fourth wave, because we do not believe that we, as an open society, where we depend whether on trade or travel of one form or another, that it is going to be a permanent situation to keep the variant out. It's just not practical, and I suspect the holiday season will only serve to add a greater risk or probability of that happening. So I take the point fully. Question, I think it was Dr. Longmore. Were you the member Longmore?
Yes. Thank you, Chairman. Good morning, everyone. Just one or two comments and a question mixed in. And I am glad that Member Allen brought the Omicron variant to this discussion now. Just last night and into this morning, I saw a study that came out indicating that it is approximately 70% more infective than the previous variants, though the infection tends to be a bit less severe. And in so doing, looking at, and this is mixed in with the case fatality rate of us being at 2.6%. And I wonder if we have looked at what factors may explain that low case fatality rate, give thanks. And when you look at the fact that such case fatality rates is comparable to more developed countries, to countries that are more better resourced, I can't help but wonder if there is something that is inherent here that our people are practicing or exposed to that will probably give that added protection. Of course, you know, I'm a big immune booster, so I wonder about our natural practices, our seasonal fruits, our diet, etc., our sun exposure, and if also at this time when we may anticipate. We see the UK also now considering mandatory boosters because of Omicron. When we are going to be anticipating that we might see increased cases coming in with the holidays, coming in with this more infective agent, is there any message that we can get out there to the persons to reduce the numbers? The other question that I have, or the other relation that or correlation that I'm trying to explore, is the death rates versus persons who are PSU. You indicated that this might be a factor in the St. Mary's situation in terms of persons who seek early intervention. At one point, our messaging earlier on in the pandemic, when we were trying to control community spread, we were telling persons to try to remain isolated, etc., etc. Is there any consideration of a change in or suggesting now that we are at a different stage of the disease, that if persons are having earlier signs and symptoms, what interventions might be necessary to prevent them from reaching that severe stage before reaching the hospitals? Because invariably, I suspect, I see where the death rates are definitely higher in the older age groups, tend to be the persons with comorbidities. So if we're able to have earlier intervention and detection at this time. The last little point that I want to make is specific to my field of psychiatry, and bringing to the fore that we are seeing persons who are normally associated with a psychotic illness. There is an atypical presentation that we're seeing, usually persons who have an atypical presentation of their usual diagnosis, and also more severe escalation in over a short period of time. This is causing a significant issue in our emergency rooms, whereas when we would normally have patients, maybe one or two persons being held in accident and emergency before being transferred to the ward because of awaiting COVID clearance, etc., we're having 6, 7 patients. Of course, this is tying up the emergency room. So just putting out that awareness that persons who may have that type of severe illness, if you're having early signs, if you're having early symptoms, if you're recognizing that for caregivers that your relative is having an atypical presentation of their usual symptoms, to take them in early so that we can administer whatever needs to happen so that we're not having that backlog happen. All right, thank you.
Thank you very much, member. The members of the team want to quickly weigh in on those 3 points.
Thank you, member, for those highlighting those concerns. I'll start with the recognition of the escalation in terms of psychiatric patients, and certainly from the team, and Dr. Williams does lead that area in terms of mental health and substance abuse, to see how best we can incorporate some of that in terms of our communication to the teams in our facilities in terms of educating their clients and their client caregivers to be more acutely aware, especially at this time, and seeking care early. The same thing would go for in terms of messaging regarding seeking care early for patients in terms of who may suspect that they're infected with COVID-19. Recognizing that, yes, we, in terms of early messaging, would have spoken about self-isolation. Certainly a part of the messaging would have been to say what are some of the more common symptoms, milder symptoms, but certainly what to look out for if it is that, you know, you're having issues and concern, and where and when to seek care in terms of whether within the public system or privately, to ensure that they don't wait until it's too late for them to actually benefit from the care that we have to offer. So we certainly will go back to some of that communication and messaging as suggested. Just as key reminders, we also want to ensure that we continue to stay on message and on point about the IPC measures, especially at this time of the year. I think some persons may have become a little tired of hearing us say it, but we need to continue to say it regardless, and also ensure that we're reminding persons that the access to vaccines is there, and they are to take up that opportunity as best as possible. I just also wanted to add that outside of the mass media communication, the teams on the ground, especially through our mobile interventions, have been doing a lot more community engagement and trying to do more of the one-on-one education, building those relationships with persons in communities, and trying to use our community influencers, you know, for example, the main shopkeeper, you know, the bar owner, those persons as our advocates within the community themselves, to see how best we can continue to mobilize. We have also at the national level and at the parish level been working with some key organizations such as the Red Cross, SDC, and other community organizations to see how it is that we can get a wider network and boots on the ground to help to continue to spread the vaccination message.
Minister,
Okay,
can I have a follow-up to that? Just a comment.
Are you comfortable with all those questions? 1 second, member.
Yes, Chair, except in that, and I wanted to bring it up from the minutes in terms of what was indicated of the treatment protocols that we were going to be updated with respect to the immune boosters, as was suggested in the minutes of the last meeting. Just to say that, practically speaking, I have had to be treating persons, and hospitals that were to be supplied with such, they were not in supply. So, you know, whilst we have it there, we might not be having the actual availability of these being applied to the patients. And again, I don't know what factors into that death rate, but I think that there are some factors that we could probably maximize on to prevent subsequent worsening.
Okay, observation taken, and we'll note that. Member Guy, can I come back to you after Member Campbell Rodriguez, since he was in the queue? Go ahead, Senator.
Thank you. I want to ask specifically about self-tests. Are we looking to have self-tests, and have we thought about the cultural context that may go with it, that if someone tests themselves and it's positive, well, I'm assuming the process here is going to be like in some other countries where you do the test and you report it in to a website or to a phone number if you're positive. So for example, in Canada, that's how it's done, right? You self-report after your test result. Culturally, I personally don't see many Jamaicans reporting that they have COVID after they have done the test because of the stigma that sometimes is attached to having COVID. So where are we with this whole self-tests, and have we thought about that component of it?
Let me comment on that from a policy perspective. So you're right. The last evening we announced that we had taken a decision as a government to purchase and distribute, initially as a public good, a quantity of the home test / self-administered test. And the decision was taken in keeping with how the approach and response to COVID has evolved over time, with new technologies emerging, assessment of those technologies, and conclusions as to how they can assist in the response. And the process of testing for the virus has evolved. The clear and most accurate test remains the PCR test, which clearly is more sensitive and is the one that is administered by the lab, and that continues to be the sort of marquee type test that is used for surveillance, which the National Public Health Lab, Dr. Hamilton is there, she can comment on it. The home test or self-administered test have become more common globally as part of screening or monitoring, and it is evolving in a sort of mainstream way for various purposes. It's evolving for access to particular events like functions. I'm sure the Honorable Prime Minister won't mind me saying that when he and the delegation went to Europe recently, they had to self-test each day and upload that information to a central database. This in addition to what they had to do prior to accessing that country in Switzerland, that jurisdiction in Switzerland. And there are other cases of such. So what we are trying to do with this recent announcement is firstly to introduce this concept to the population. You're right, the culture does have its own unique features. not for surveillance purposes. We will remain with the tried and tested and proven technologies for surveillance. But we do recognize that there are some environments, whether in the home or the workplace or for special events, where a home test would serve as a complement to the other systems that we have. Having said that, it does come with potential disadvantages. And I think part of the public education is to outline what this means. So for starters, you're right, if not administered properly, you could get a further deterioration in the accuracy levels. Persons can in fact manipulate results depending on the context of application. It may not be wise to do so because you'll be fooling yourself. If you really have the virus and you place yourself and those around you in danger, but unfortunately there's that kind of deviant behavior that could apply in some instances. Beyond that, the self-administered tests do come with greater margins of error than the PCR. And I think what is important for us is, one, we identify the kits that have been subjected to certain levels of clinical trials, so they are relatively predictable if applied properly. And so we have insisted on the WHO or FDA emergency approved or emergency authorized kits. And we have encouraged private sector entities to bring those in. And there are about 2 or 3 now that are being looked at the level of the standards agency for permits to be granted. So that's one screening of the type of test. The other must be to accompany the introduction of these kits with the advisory, as I have stipulated, around approach to usage, the possibility of margins of error, and again, to keep that out of our surveillance operation as a country, as a public health authority, so that it does not in any way run the risk of compromising any assessment as to the state of the virus in the population. So it's important to note that it is in that context. What I think we cannot afford to do or should not do is to ignore the emerging technologies that could add some value, even incremental value, to the process of the COVID response, particularly if the intention is to deal with the realities of living with COVID as opposed to eliminating COVID, which, as we know, is not going to be the case. So we're venturing on a new territory. We're learning from how others have done it. And we do anticipate that it comes with challenges, but COVID has been a range of challenges. So I don't think we should be intimidated by it. I think we just need to recognize the pitfalls and also the advantages and manage in terms of the advice and the education that we provide to the populace. So I don't know, I'm going to come back to you. I don't know if anybody on that side, is that sufficient, Dr. Hamilton? Now, I know my clinicians are very conservative, let me just say, and they would much prefer to just use the PCR. Let me let them off the hook, because that is the high science. But we always have to balance the need for the need to advance the process, and there are some risks involved in advancing that process. So I'm going to say that I am sure they would much prefer to just administer PCR tests, right, Dr. Hamilton? The antigen test comes with its own downsides too, because antigen tests, which are now allowed, if you're asymptomatic, it comes with greater margins of error than if you're symptomatic. So I'm sure we get some false positives and vice versa using that test. I think the self-test may introduce some of that too, but nevertheless, the technology is improving and we have to work with the technology as the context dictates.
Mr. Chairman, on that same question that I just asked, I just want to say, When we start doing the self-administered tests, as usual, we have to have a little campaign around it. And I just want to say for the record that you have had 2 COVID jingles, 2 of them. The last one, you can withdraw it from the radio completely. It has no effect. It doesn't touch anybody. I can't even tell you it go. While the first one, I could sing it for you because it does, so it resonates. But the last thing that you have had on COVID, it doesn't resonate. But the first one, that one resonates. So
the Christmas one?
She says she can't sing it.
no, you're not going to get me
She
to
says
embarrass myself
she can't
today.
remember it. All right,
Right?
we look into it, member.
Yeah, but the second one is not happening at
If you
all.
want to be a hero on the scene, you take the COVID vaccine.
That one resonates
Oh, the
much
hero
better.
on the scene. Okay, fair enough.
Yes, that one I think resonates much better than another one that you have had more recently. Some other messaging around COVID you have had more recently. I can't even remember how it sounds. But we have to make sure Jamaicans love something they can dance to and feel like they're moving their bodies even when they don't need to. So the messaging has to be appropriate.
PS, please take note of that. We'll mention it to the communication team, and the feedback is always welcome. I really was supposed to go back to member Guy, unless it's on this issue.
It's on the self-testing.
It's on the same issue. Okay, both of you
I'm
on the
sorry.
same issue?
No, totally, I'm
Separate?
not-
I'll come back to you.
Okay.
Go ahead.
Minister, when I learned of the self-testing that was being introduced, it falls squarely into a conversation I had with a tourism partner just last week, I believe it was, in terms of suggesting that this would be, the more you test, of course, the more we know our true situation, and encouraging the matter of self-testing. So when I just want to comment on the fact that having now learned of this, and I appreciate that it is going in the direction, and it's very much in line, especially with tourism, because at the end of the day, the more we are able to test and know the true position of where things are, the better off we'll be. And certainly we know that antigen tests are ranking up there in terms of percentage of, what's the word I'm looking for? In terms of accuracy and yes, specificity. So I just wanted to acknowledge that, and apparently Ministry of Tourism and Health are on the same page in that regard.
Yeah, well, we're on the same page in responding as effectively as possible to COVID, but health also has a greater responsibility around the public's protection against the virus, and it's important that we also have to give the advisory around these tests, because if not administered properly, could serve the purpose of trade or movement of people, but may not serve the purpose of properly monitoring the extent to which the virus is present in the population. And so I have to always, as Minister of Health, and may even irk some people who may not agree with adding the advisory, but I have a duty, as well as a team, to always attach the advisory that the self-test is not a panacea. It is part of a process, it's evolving, and its accuracy is less, and I dare say far less than the PCR, and how it is administered will also determine that. And the reason why I raise it, sorry to be long-winded on this, the reason why I'm raising it is because we also have to be careful that we do not promote a sense of complacency in a population that may have administered unto themselves a test in a manner that is either not properly administered or gives a false reading, and then all of a sudden we go around spreading a virus that was not picked up by a not as accurate test. And I think we have to place that on record, and we have to use the opportunity to encourage Jamaicans, if you are in doubt, if you have symptoms, no matter your self-testing, see your doctor, get a proper test, isolate, or as the case may be, and always take the extra precaution. That's the point I'm making. Thank you very much.
Agreed, Minister.
Okay, yeah, go ahead.
Thank you, Minister. Chairman, I just want to comment a little on the last matter, because I do agree with Senator Rodriguez that the message has to be very important as it relates to the self-testing. and what goes out there, and it is something that your team will have to look at really seriously. But there was something Dr. Spence commented.
But Guy, does that mean, sorry, that you won't complain that it is going to be done? A proper messaging campaign, sir?
That I
just
won't
asking.
complain?
Yeah.
I've never complained about messaging.
Just asking.
No, I've never complained about messaging. You talk about something else. No.
Go ahead.
And the minister know what you're talking about.
Go ahead.
All right, Dr. Spence, the whole issue of the community influencers, and I want to share with you, but there's a concern that even though they're out there, the reach is not far enough. And I would encourage you to have your team work harder with them, right, in getting, so that you can categorically say that even though we have a few, categorically say after, we have a whole, a vast number of influencers out there encouraging vaccination for the people in the respective communities. Because, you know, Minister will tell you that from day one, when we sat at your ministry, right, the community influencers weighed very heavily in my discussions about what needs to be done. But there's another question, Minister, if I may ask, and it's allied to all of this. But does the report from in terms of the numbers of tests done each day, do we include those that are done for travelers? We do. Well, I have a problem, because if we do include those that are done for travelers, we are not capturing all of it. Look, just an example. We report about, yesterday's numbers were, in terms of travelers, let's see. We had from the private laboratories yesterday, 259. Yesterday, 259 from the private laboratories. Now, 25 flights leave Jamaica each day from Montego Bay. Assuming at the very, very minimum 100 persons per aircraft, you're looking at 2,500 persons. 17 flights are leaving Norman Manley today. And if you do the maths, you're looking at 1,700. That is 4,250 at minimum. We are not getting the numbers from the airport. And Minister, if we did, you would look better, because your positivity rate would fall, right? No, it is something that needs to be looked at. We are not getting those numbers sufficiently. Oh. And if you say you get them, even if you say not getting them on time, if you add up, you still have a significant lag period.
All right, let me ask, is it Dr. Hamilton or Dr. Spence? Who wants to comment on that?
Okay, I just saying the numbers that are given on the private antigen, it's private antigen. The PCR is included in the other. So we would have had 1,100 and something tests for PCR. I don't know how many were private PCR. So so
the vast majority of those who travel, except those going to Canada or to Cayman, everybody else is antigen. So the vast majority of those 4,200 that have just the minimum are antigen tests.
Dr. Hamilton, you want to come in?
Yes.
Dr. Hamilton, head of the Public Health Lab. You have to go? Okay.
Dr. Guy, it used to be that we would see most of the travelers going with antigen tests, but it varies. For example, yesterday, we did have 259, you're referring to, for the antigen test, but we had over 1,000 PCR tests reported for private travelers. It's some days you have less antigen than PCR, and other days it's the reverse. So it's not just that we can say for sure that most of the persons are doing antigen tests. Some days you actually have more PCR tests than than antigen tests being done. But I understand the point you are making that all of the tests may not be captured, and this is why we continue to follow up on the labs that are out there. The ministry has an approval system in collaboration now with JANAC to ensure that labs are approved by the Ministry of Health and or pre-accredited by JANAC. And part of that process includes a reporting mechanism on a daily basis. So what we are aiming to do is ensure that all of the labs that are testing are approved and or pre-accredited, because those have a direct relationship with us in terms of reporting. And at the same time, we need to ensure that labs that do not have this approval or pre-accreditation status are not offering tests, because that is where, if a gap exists, that's where you'll be likely to find the gap.
Member, let me try to bring some clarity to this issue, because I'm understanding you to say something which I'm not sure is being responded to, because there may be some misunderstanding. And PS, you can come in here. I'm not of the view that we capture the tests for the tourists leaving the island doing an antigen test as part of the surveillance of the virus in the population. PS, you want to comment on that? Because I think that's what you're asking when you spoke of flights going out.
So it's not necessarily a clarification. I think Dr. Webster made the point that in the calculation of the positivity rate, there is a sort of, not all of the antigen tests that are done in the private setting that are included in that number. Am I correct, Dr. Webster? So yes, you will see that quite a number of tests are done in the private setting for travelers, but they are not necessarily included in the calculation of the positivity rate for the day. So, for example, we did a total of 1,706 tests yesterday, of which 7 were positive, okay? But in terms of the tests, total tests in terms of the private setting that was done, not all of them were included in the number to arrive at the 3.4% positivity rate that we recorded.
Yeah, I hear that, PS. Minister, Chairman, if you'll allow me. I hear that. But if we go back to what Dr. Hamilton just said, over 1,000 tests were of the 1,706 that was done yesterday were PCR, which came from the private labs. So those are captured, right? But what I see here is that your numbers what they're basically saying is that 2 things. One is that you don't have 1,000 persons traveling to either of these 2 jurisdictions every day. So it means that the labs are not feeding the results in on a timely basis.
No, it's 2 different issues.
No, they're 2 different issues, but they're all tied.
Yeah, they're all tied. But
because what will happen is that if you get 1,000 results today of PCR, right, and your public health lab only does 700, 1,000 from the private labs and 700, right, it gives the impression when you're calculating your positivity rate that it is low, right? Whereas if you had gotten them on the days that they were done, they'd have a different result. So we're not really calculating it properly per day. That's the point I make.
No, and it's difficult to do that, you'll accept, because we don't have necessarily control over the reporting. We have a standard for them to give us the report, whether or not they comply with the standard. And so what you find is that what the surveillance team does is that they calibrate the information to reflect the timelines that they have, so that the numbers that you see in tables that we present and the graphs that we present are calibrated based on the dates that we would have received the different results coming from. But the point that I'm trying to make is that in the calculation of the positivity rate, member, we do some disaggregation of the information that comes in, and we do have the ability to calculate the positivity rate based on the algorithm that we have defined for the testing for COVID-19.
So, PS, garbage in, garbage out, simple. If you do not give the correct numbers for each day, the algorithm is not going to give you the correct.
Member, this is where I will intervene here, because I cannot accept that we're putting in garbage in the system and therefore getting garbage out. So maybe those are very strong words. No, it's very strong words, and I respectfully...
Chairman, you know,
yes.
and I don't think you need to comment on it. We're talking about like computer technology, and there's an age-old adage which says garbage in, garbage out.
But for fear of misinterpretation, I want to be very clear that the team has, in fact, and the historical data confirms this, that the numbers that are put out on a daily basis over time tells a particular story that links positivity rate, reproductive rate, with hospitalization rate, with death rates, and it confirms after the fact that the surveillance that is done and reported each day is accurate within the margins of error to provide appropriate levels of planning and response. And I don't think any Jamaican will disagree with that. Let me just say for the record that that doesn't take away from your point, and a point that doesn't need the kind of exaggeration that you have placed on the records. That respectfully I say that we can enhance the process. And I'm all for enhancing the process, and you have been quite constructive up to a short while ago in adding value to how we can enhance that process. What I will reiterate, however, is that there is a formula around how the rates are determined, and Dr. Webster-Carr, you probably need to be clearer given the work you have done, and I commend you for it, you and your team, on how that formula is determined in terms of a percentage of antigen versus PCR. And it has its genesis also in the accuracy of the PCR as opposed to the antigen. It's the same point I was making around the self-administered test, which is why that can't be and will not be a part of the overall determination as to the level of positivity in the population. So because of the nature of the antigen test, where if you are not symptomatic, the chances of getting an accurate reading is diminished. And indeed, frankly speaking, if we are to be very clear, a lot of the testing that is done for travel purposes cannot be included in surveillance because it meets a requirement that is not necessarily clinical, strictly speaking, but more a requirement that is more around trade and movement. And at some point, we have to confront that reality. The requirement to do a test to travel, if it's an antigen test, is not as accurate a screening process as many of us know. It is the PCR that would have given you that more accurate reading, but then it comes with its own challenges, the length of time, the delays, the bureaucracy, the cost. And, the world will have to come to terms with this over time, I believe, my view. So when someone takes an antigen test at the airport, rushing to get onto a flight, it's because more often than not that the airline requires it and the country requires it. It's not necessarily, and perhaps not primarily, because we want to determine whether they're positive or not. And I know I'm courting controversy by saying this, but the truth is, it is increasingly becoming an expense that perhaps is not worth it. But it is what it is. It's an international requirement. And we will have to lobby in the halls of our multilateral partners, our trade partners, to find a mechanism that balances the movement and trade requirements with the clinical requirements. For us, as we carry out our primary burden of surveillance, we have already taken that into account, which is why we discount the antigen contribution, the antigen test contribution to the predictions that we make, our forecasting. We stick with the PCR as the marquee test and discount that significantly. So it's not a matter of garbage in, garbage out, member, and I know you're going to take that back. I know you didn't mean it. It is a case of assessing and finding the best possible mix, and I think the team have done well to date. All right, so I'm going to, unless you want
Chair,
to take it back, I'm going to go
we'll
on
end
to...
on a lighter note, Chair.
Yeah, I'm just...
We'll end on a lighter note.
We don't need to belabor the point.
Yeah, okay.
Yes.
All right, so we're on the time now. I'm going to ask the final question, if that's all right.
Very light note. For the record, I'm pro PCR. But there are quite a few persons who have been asking, Chair, in relation to the booster shot. Can they apply using the One Love number to make an appointment, or you can just walk in? Both?
The ideal scenario is to make an appointment, but we do appreciate some of the concerns sometimes raised about not getting through. If you turn up at a health center,
it would appear there's space in St. Mary.
I just got a note that says the Girl Guides headquarters, where they're now administering, is empty. So that's the challenge we face. Many people are not going out and many not using this. If you turn up, we're not going to refuse anyone. Sorry? Oh, you're inviting her to St. Mary. Member,
yes, Chair. And, pardon me?
The member guy is inviting you to St. Mary.
I'll consider that.
Okay.
I'll consider that, member. But I think we also should remind persons that it is 6 months after the last dose, the second dose, that you are eligible for the booster.
Agreed. And we have put out that advisory. All right, so can we move on now? I really think we have gone through a number of issues, and I thank the team again and members. Can we move to item 8 in keeping with our time? It's now midday or 2 minutes after. Any other business? Well, firstly, any other business? No? All right. Before I ask for the date for the next meeting, which maybe we may want to wait until New Year to determine that, given that we're going into the season, I want to just, first of all, prior to adjournment, thank the members. Really want to thank the members for their contribution. And I want to say thanks to the opposition members. And Member Guy, you have been most constructive in the period, during the period of the COVID response, and I really appreciate it, I do. I think there is a recognition that these are unprecedented times, and the challenges far outweigh the opportunities, if you will, for political point scoring and so on. I think the spirit of the committee has been in keeping with what is in the best interest of the country, and I want to say thanks to you and your team. I want to thank members as part of the administration who have served and who have attended the meetings. Thank you for your ongoing support and comments. The health team, really appreciate the support, the PS, the CMO, Dr. Webster Carr, and the others who have been here and have been willing to share. And, we have really approached this in a way that has allowed us to accept criticisms or suggestions. And I think that is the spirit that would have advanced the response. To the parliamentary team, thank you very much. You've been very vigilant in setting dates, doing the follow-up, and really giving the information as required. To the contrary, I want to really say that we continue to struggle with the response. 2021 has been a year to remember, not necessarily for all the good reasons, but we should really take comfort in the fact that as a country we have persevered, we have remained committed, we have remained focused, we have seen frustrations, grief, death, and we regret all of that, fatigue, tire, challenges, but we have also seen triumphs. We have seen our resilience on show. We have seen the innovation of ideas, the adoption of new approaches, the creativity of the people, and the willingness to coordinate and to cooperate in response to what is a threat to all of us. And I really want to pay tribute to us as a people and as a country, because we are, I believe, after this is over, we'll be better off for the COVID experience in terms of what we have learned, the lessons, and in terms of building back a more resilient health system. I would like to continue to advise that this season is a season when we are tempted to indulge. Nothing wrong with that. I think we all deserve it. But do so advisedly, recognizing that the virus is still out there and it does pose a risk. So observe the protocols, the mask wearing, the congregating, all the protocols that are there. We are working on a plan to continue beyond the new year. The digital cards will be out. That wasn't mentioned, but I want to commend those who have really met the deadline for that, the digital vaccine cards to be out come Monday. Just go online, get the information, or get some information from your health center. The team has done well. I've seen the demo. I'm very comfortable. This will be in keeping with international best practices. The test kits is a new addition, the home testing. Let us work together and recognize it for the value it creates. And of course, as one addition, we're working on additional beds for the fourth wave. And where we had bottlenecks last time, two particular areas. Personnel, we are holding with the temporary workforce that we have put in place until the end of the quarter to ensure that we are not short of staff. And oxygen, we have taken some decisions to expand on that. So I really do think we're in a good place, a good space, and I really do think we all deserve a rest or a break. And I'm going to encourage all of us to do so, recognizing that we have done well. And I want to thank the team again. Thank you very much. And we will pick up in the new year when we'll set dates for the next meeting. Can I have a motion for adjournment? Or?
Chairman,
yes,
on the motion for adjournment, I just want to echo some of the sentiments that you have made, and particular to the health workers, the team from the ministry and those who have been out there toiling in the field. The nation owes you a debt of gratitude. And we just want to say to you, keep on keeping on. But I just wanted, my particular point now, Chairman, is that I thought when you were commending the team, the only thing that you had left to say was that there's a cake outside for each of you,
I thought about it, but I am also waging a campaign against excess sugar.
I know, but there are some that don't have excess sugar. I have
instructed the Parliament to provide some water, the best rehydration.
Well, Minister, if you want my comment, I had to say to the CMO the other day at the Pegasus when I joined you, that this food that you have eaten out there is not what the Minister is advocating.
All right, we have a motion, please. So moved by Senator Campbell Rodriguez, seconded by Member Hamilton. Thank you very much. Thanks again. Have a good time. Thank you, ma'am.
Jamaica.